Many of you know about the characteristic stroke symptoms like weakness or numbness on one side of the body, but did you also know that a sudden, severe headache might be a sign of a medical emergency just preceding a stroke? You should learn the signs and symptoms of stroke using the mnemonic BFAST, or B-E-F-A-S-T. It could save your life. In this week's Health Talk, we'll discuss the symptoms and types of stroke with neurosurgeon Dr. Jon Lebovitz. So stay tuned, Health Talk is up next. Hello, I'm Dr. Eric Mazur. On this week's Health Talk, we're going to discuss the symptoms and types of stroke. We've got a great guest. He's neurosurgeon Dr. Jon Lebovitz from Nuvance Health. It's great to have you on the show, Jonathan. Welcome to Health Talk. But Jonathan, you're also, I guess you're not that new here in Nuvance anymore. 2.5 years.
Yeah, 2.5 years. Well, thank you. Great to be part of the show. Thank you.
We're so lucky to have you. You really do some really remarkable things. But before we get into some of your technical prowess, and which I think is really sort of amazing, just tell us a little bit about today it's important that we recognize a stroke early and seek help early. That's so different than when I was practiced years ago. Why is it so different now?
So since when you were in practice years ago, the types of treatments that are available have changed significantly. And now, depending on how early one gets to the hospital or gets to treatment, there's different medications, such as IV medications to break up a blood clotting type stroke, or even advanced surgical interventions where we can go through the arm or the leg to go and actually retrieve blood clots from the brain through the blood vessels themselves.
It's really interesting because I've certainly seen this evolution for the heart, where we used to just sit and watch a heart attack happen, and now we aggressively intervene to get those blood vessels open. Stroke sort of came a little bit later along that line, but we're saving brain just like we save heart muscle now, aren't we?
Exactly correct. And the neurosurgeons kind of piggybacked a little bit off of the cardiologists and saw what they were able to do for the heart. And as the technology advanced, we were able to do the same type of treatments for the brain.
Now, Jonathan, I learned way back in medical school that if brain doesn't get blood flow, it dies in 4 to 6 or 8 minutes or something like that. Why does it work that if you get there within several hours, and we'll talk a little bit about that because that's getting bigger too.
Sure, that's changing.
But if you get there within several hours, why is it that you can actually get function back?
So there's many different ways the brain gets blood, and depending on which blood vessel may be blocked, there could be alternative routes that the blood can take, or some lesser used blood vessels can become more used during that time period. So the brain has a robust network that can try to save itself during the time you're having a stroke. So that's why the sooner you get there to reopen the blood vessel, those kind of alternative pathways might go back to normal once the normal route is unblocked.
So they've got sort of, a lot of the brain may have some emergency blood oxygen and glucose to feed it so it stays alive barely, and then if you can read. So that's really sort of amazing, because I think that was the first thing that needed to be shown, was that you could in fact save brain, retrieve brain.
Yes.
And you must have some examples of people who've come in with strokes that do dramatically well. I mean, I've read amazing things.
And so we had, patients can come in within minutes or hours, and some people, due to some of the advances that we have in these, blood vessel networks we talked about, can come in up to 1 day after their symptoms started and still have good outcomes. And it's really about these collateral networks that help keep the brain alive while they're waiting for treatment.
So I mentioned during the tease BFAST.
Yes.
B-E-F-A-S-T is sort of the early warnings of stroke, which is really important for people at home to know. What are the symptoms that should prompt a call to 911?
Sure. So, the BFAST mnemonic, B is for balance. So if someone is suddenly unable to walk or keep their balance very well, that could be an early warning sign of stroke. E is for eyes. Some people who have a stroke won't be unable to look to one side of their body or their world, or have blurry vision, double vision. F is for face. If you might have an asymmetric face, a little droopy face, or smile doesn't look normal. A is for arm. Your arm might not work very well or will have some weakness. S is for speech. You have a slurred speech, or unable to talk at all sometimes. And then the T is for time. The faster you get to the hospital for evaluation and treatment, the better chance of having a good outcome you would have.
And when we say get to the hospital fast, you want to say a few words about what people should do, because I know a lot of folks say, well, I'm just going to see if it goes away, or maybe I'll take a nap and see if I get up better. I'm as guilty of this as anyone. You want to deny that these things are happening.
Sure, of course.
So why is it so important to get to the hospital?
So all of our treatment regimens are time-based. So the first 4.5 hours after your symptoms start is when you're a candidate for these IV medications to try to break up any blood clots in the brain. And the more advanced interventions, like the surgeries that I perform, are up to 1 day. So the longer you wait, the amount of different treatment options that you have decreases, and the chance of a long-term neurologic issue, or that whatever your symptoms are being permanent, increases with time. So the sooner you call 911 or get to the hospital, the better chance you have of getting.
And this has really been proven. I know that they've done careful studies looking at the time, and we're not just saying it because it makes sense, but it's actually been shown the faster we're able to get there and we can intervene, the better the outcome is going to be on the other side.
Yes, that's exactly correct, and it's kind of what you said. We've learned and known for many, many years that the brain itself, once there's a part of the brain that doesn't have blood flow and kind of dies off, that part doesn't get better. There's no regeneration of the brain like there is a muscle or something like that. So you're going to deal with, again, these alternative pathways that the brain can establish to function, but the more brain that is not surviving, the less robust these other options are for the brain to have, which is really why the faster you get to the hospital, the better.
Mm-hmm. Yeah, I guess for folks at home, you can think about it that the brain gets fed by an artery, and that artery gets clogged. Well, there's sort of a central part of that may die.
Correct.
That it doesn't have collateral blood flow, but then there's a whole surrounding area that's hanging on by their fingertips.
Correct.
And it can only hang on for so long, and it may hang on for a few hours, it may hang on for up to a day under certain circumstances, but it's just hanging on. And once it finally dies, again, we can't fix it. But
Correct.
if you can get in there early enough and restore blood flow, people really, well, you can tell us about it, but I've certainly seen people who can regain function. Their arm is weak and they can't speak, and all of a sudden, the stroke symptoms go away.
There was a lady that we treated a little while ago who was out to brunch with her friends, and during the brunch she suddenly had the inability to talk and move the right side of her body, and she came to the hospital. She had the stroke evaluation. They did a special CAT scan that actually looks at the blood flows, called the CAT scan angiogram, that found the blockage. And once that blockage is found, she's a candidate for the stroke retrieval surgery. We took her to the operating room. We went through the blood vessels. We were able to retrieve the blood clot, and she actually started talking, on the operating room table. Once we were done, she kind of perked up and woke up right away.
Are people awake when you? Well, we'll talk about the endovascular another time.
Yeah.
But I just think it's amazing. So yeah, it's really astounding, and I know that all these studies have shown that long-term disability, particularly disability, is reduced by early intervention. So
correct, and stroke is one of the leading causes of disability in America. So, I think it's something like $50 billion we spend, on stroke care and stroke recovery and all that. So the more brain function we can save, the better patients do, and the more functional everybody is, and things like that.
So some people will wake up with new symptoms.
Yes.
So, and I think that's fairly common. They'll wake up and they'll find, my arm is flat. What then? Is that an emergency too? Should they come in?
Yeah. So a wake-up stroke, again, years ago was not an issue, and now what's considered a wake-up stroke we're describing is still a medical emergency, and because of the advanced imaging that we have that kind of actually finds exactly what you just talked about that core, that brain that's dead, and that surrounding area. In medical terms it's called the penumbra, but that's essentially the same thing you talked about. We were able to obtain imaging that will prove that the amount of brain that is still hanging on is significant, which then means that we can go do these blood clot retrieval surgeries to restore blood flow and save, again, as much brain as possible. So yeah, if you wake up, that still is call 911 or get to the hospital by a family member immediately, because that doesn't mean that you're not a candidate for any treatment.
And I guess we can't emphasize this enough. Don't pack a bag.
No.
Don't call your aunt.
Yeah.
Or your kid.
You don't need your cell phone or your charger. Just
and don't
get
be
to the
embarrassed.
hospital.
The other thing, embarrassing. Some of us don't like to call an ambulance and are embarrassed if you get in and it turns out not to be a stroke. Do you want to say a few words about that?
I think that if you're having some sort of neurologic event, a bad headache, you can't speak, your arms or legs aren't working very well, I don't think there's anything to be embarrassed about. And it would make everyone probably happy at the hospital that it wasn't something like a stroke and it was some other transient event that went away. So I don't think that you should be embarrassed at all. If you're not acting yourself and there's something that's concerning you, it's always best to seek treatment right away.
Absolutely, that's what we're here for.
Yeah.
And keeps you on your toes, I'm
Yeah,
sure.
for sure.
Because I can see, you'll stroke and you're running into, you literally run into the hospital if somebody needs you. You're not waiting till you're finished with your last patient.
Yeah, no, it is. We have to basically drop what you're doing right away because of all the things we talked about. Time is brain, and the faster we can get that blood flow reestablished, the better people do. Again, similar to the cardiologists and the heart attacks that we talked about a few minutes ago.
And Spielberg even called it a brain attack, which I think sort of makes people think the same terms. I don't want to miss discussing this. I talked a little bit on the introduction about different types of strokes.
Sure.
I think we've been talking about mainly the most common type of stroke, which is when a blood clot either travels to an artery or because of arteriosclerosis forms an artery. Tell us a little bit more about other types of strokes.
So in broad categories, there's the blood clotting type strokes that we've talked about, and then there's the bleeding type of strokes. And the bleeding type of strokes have a couple different categories. So one would be that bad blood vessels or high blood pressure, things like that, can cause actually a blood clot in the brain. And that would be, again, the next most common type of stroke. And then there's other types of strokes, like if you have...
Can you just, before I go on, the blood pressure stroke, I know it's much less common. Are you able to do any interventions to help in that other than manage the blood pressure properly? Because it often involves smaller arteries, isn't it, when they bleed?
Correct. So there's no like direct blood vessel intervention we can do for the blood pressure type strokes. There are some minimally invasive open brain surgeries to help reduce the overall disability that blood clotting stroke, that blood pressure stroke could show, but they're not very good treatments, to be honest with you, and we're still trying to.
Which is why it's so important to manage your blood pressure and your cholesterol, because that's what you can manage those. But then there's another type of bleeding stroke. Tell us more about that.
So the other type of bleeding stroke would be something from like an aneurysm, which is a blood vessel abnormality, kind of like a balloon, where you can get some bleeding from that ballooning of the blood vessel, which is another life-threatening emergency. And it presents a little bit similar, but also at times different than the other stroke we talked about, usually with the worst headache of someone's life. And then there's different treatments that we can do, again, through the blood vessels, the arm or the leg, to kind of block off that.
That's what people call an aneurysm, right?
Correct.
And we'll talk about that another time, but I think that's a really good place to end.
Yes.
This has really been very, very informative and very important. This is practical knowledge for our folks at home.
For sure.
Because we can really help out there. That's all we have time for today. I want to thank Dr. Jonathan Lebovitz for joining us on Health Talk, and thank you for watching. Please share your comments and questions with us by emailing healthtalk@newvancehealth.org. We'd love to hear from you.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself. I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
The treatment for stroke has changed drastically in the past couple of decades. Today, if you or a loved one has a stroke, there are new treatments available that are improving outcomes and helping people remain functional and maintaining their quality of life. On this week's Health Talk, we'll discuss the latest treatments for stroke with neurosurgeon Dr. Jon Lebovitz. On this week's Health Talk, we're going to discuss recent advancements in the treatment of stroke. Our guest is neurosurgeon Dr. Jon Lebovitz from Nuvance Health. Jonathan, welcome to Health Talk. It's so good to have you here.
Thank you for having me.
And as I've said, welcome to the community because we're so lucky to have you and your skill set here.
Yes, thank you. It's been excellent since joining the team here about 2 years ago.
Well, as it said, this is just so. This is a remarkable area. As fun as I get older, watching the advances in medicine literally leave me with my tongue hanging out. Because stroke was one of those diseases where we did nothing. We just sat and watched it happen, and it was sad.
For sure.
And maybe we could prevent them. There were things we knew, but we couldn't treat them. And today there are all these interventions available.
Yes.
So do you want to kind of go through some of these interventions? Well, before we do that, let's take stroke. There are two types of stroke.
Sure.
Yeah. Tell us a little bit about that, and then because the interventions are very different for the two.
Yeah, so the two different types of strokes are first we talked about the most common, an ischemic stroke or a blood clotting type stroke, where there's different medications or surgeries that I can perform to restore the blood flow and to remove the blockage. The other type of strokes are the bleeding type of strokes, which can be a blood clot within the brain, usually from high blood pressure, or a aneurysm, which is a blood vessel abnormality, kind of like a balloon that can cause leaking of blood into the brain, that has a treatment that we can now do in a minimally invasive way.
The latter is amazing because I do remember aneurysms. They've been around for forever.
Sure.
And I don't know whether people at home still understand this. They were like the ballooning of an inner tire, an inner tube, where
yes.
a weak spot would balloon out.
Exactly.
And
correct.
that weak spot tends to bleed.
Yes.
And I remember the surgery used to be very complicated and often very morbid. People often were left with neurologic residua after those types of surgery, and that's changed dramatically, hasn't it?
Yeah, so the classic surgery involves open brain surgery, incision in the scalp and removing some bone and going down to the base of the brain where most of these aneurysms are.
Yeah, that's pretty deep in there.
Yeah, it's not on the surface. Yeah, and actually taking like a clip and trying to clip off that ballooning. And now with our advances in technology and even equipment we have here at Norwalk, we can go through the blood vessels of the arm or the leg and take small tubes or catheters up into the brain to treat the aneurysm in a minimally invasive way.
So how does someone know they have an aneurysm? Who's at risk?
So there's a small population of people that have a family history of aneurysm, but most people are just sporadic or bad luck. There's certain lifestyle things, smoking, drug use, high blood pressure, things like that can increase one's risk of having an aneurysm. And most are found, kind of incidentally. They have a headache, they have dizziness, they have some other vague neurologic symptom that would get them an MRI that might show an aneurysm. The other population of people are the ones that come in when the aneurysm have bled. And the most common symptom of that is the worst headache of life.
Yeah, do you want to say something? Because that is, this is not, people have headaches all the time.
Sure,
and I don't want everybody running in because they've got an aneurysm.
Right.
But that is, I've heard that over and over again. You've certainly seen it in your practice.
Yeah.
People say, this is a word, come on like that? Is it a?
Yeah, it's a sudden, kind of what we learned in medical school. It's a thunderclap headache. It starts right away. It's the worst headache they've ever had. It's unrelenting. Sometimes it's to the back of the head and some neck pain, things like that.
And this is from bleeding into the brain,
it's
right?
From bleeding into the brain, yeah.
And they often have some neck stiffness too because of the blood that goes down the spinal canal.
Yep, and the covering of the brain called the dura can get irritated from that blood, which can cause that neck pain.
So if you have a sudden headache, again, sudden severe headache.
It's the worst. It's different than maybe your normal headache. That is another reason to call 911 and get to the hospital right away. And it's important to utilize the EMS services to let the hospital know so the hospital can be ready and get everybody prepared for a possible emergency situation.
When they come into the hospital with this severe headache, what happens to them? I know you get called, so
yeah.
you're running in day and night. You're coming in.
So the first step in the emergency room is going to make sure that the normal things are okay. Their blood pressure is okay. Their heart and lungs are okay. They're breathing okay. And once all of that is situated, they, God forbid, need a breathing tube or something like that, they'll get CAT scans. And the normal CAT scan to look for bleeding in the brain, and then a special CAT scan called this CAT scan angiogram, where they actually put dye in the IVs to look at the blood vessels to see if there's any abnormalities like an aneurysm.
So they can actually see that without a special study doing an arteriogram or something like that.
We can find, almost all aneurysms with the quality of the CAT scans that we have today can be found with a CAT scan angiogram.
And so you find somebody's got a bleeding aneurysm. They may have some neurologic deficit. They may not. Do you treat it emergently? So
that's also changed since, back when you were in medical school. It used to be we would do that kind of day or night, and at this point, for an aneurysm surgery, we tend to stabilize the person and make sure, again, all the normal things are okay, blood pressure, heart and lungs, and do it either later that day if it's during the day or the following day first thing in the morning. But we generally don't treat aneurysms like 2 in the morning or something
That's
like
interesting. I didn't know that.
Yeah.
Yeah, well, that makes sense because you certainly want the team to be there and people to be...
Exactly, and that's been well studied and proven that the correct people in the room leads to a better outcome. And 2 in the morning, you don't always have your full team.
So you told me something before the show that really blew my mind, and that is that you actually can run the catheter not through the big artery in the arm, but through the radial artery, which is at the base of your thumb.
Correct.
And the reason I was smiling when you told me that is that I used to have to, as a medical student, puncture that, or actually as a resident, puncture that artery to get blood gases of patient to the ICU. And that was hard.
Yeah.
It was hard to hit that spot. You could feel it. But I can't imagine doing a catheterization. Say a few words about it, because I'm really sort of awestruck by that. I know that's not your biggest skill, but that's one that I can appreciate.
Yeah, so that's changed. And, I'm the first generation really of neurovascular neurosurgeons that have gone through the arm. Routinely everyone goes through the leg, and that's one of the skill sets that I brought here. Is one of the newer trained people to go through the arm. And
why go through the arm? There are certainly reasons to do that.
Yeah, so the main reason to go through the arm is it's safer. There's theoretical risk when you go through the leg that there can be, God forbid, bleeding in the abdomen that can be life-threatening. And when you go through the arm, there's nowhere the blood can hide if there's a problem. You can see your arm everywhere, and if you have bleeding, just like when your thumb bleeds, you can put pressure on the arm. So it's overall safer, and patient comfort is very important. And when you go through the leg, you need to lay flat for 4 hours or 6 hours because you need
literally, when you say the leg, you're talking about going through the groin.
Going through the groin, exactly. And you have to lay flat for 4 to 6 hours afterwards, when if you can go through the arm, they just have to wear like a little wristband. They can be up and walking. They can be sitting up. You can go to the bathroom. They can eat.
As a hematologist, I used to get called after groin catheterization because you could put a couple of units of blood into your leg and really not know it.
Right before you would know it, exactly. And then again, that's why being able to go through the arm is just so much safer.
Yeah, it's sort of amazing that you're able to do that. And so you will thread this catheter up through the arm.
Yep.
And take us on a tour.
Yeah, so you put what's called a sheath, which is basically your highway between the outside of the body and the blood vessel. And you can place these small catheters, which are tubes, and that you use wires to kind of drive them. And you go up through the arm into what's called the aortic arch, or right above the heart where all the great vessels come off. And the catheters that we have now basically have like a U on them that lets you kind of, instead of going down into the heart, you can reverse the shape of the catheter to go up into the brain. And you bring these other systems into the carotid artery in the neck, into the internal carotid artery, up into the brain to wherever the aneurysm or problem is. And
you say that as if that's an easy trip. I don't get it for the folks. This is a complex vascular system where you're making lots of turns.
Lots of turns.
To get up to a fairly small arterial system up here at the base of the brain.
Yeah, and then so the size of the blood vessels in the brain are sometimes less than 2 millimeters, which is very, very tiny.
Eighth of an inch, something like that.
Yeah, very, very tiny. Yeah, so and that's why now at Norwalk even we have a new what's called a biplane angiography suite, which has 2 X-ray machines that you use simultaneously because of all you were saying, these small blood vessels, the twists and the turns that you need to be able to see things.
So this gives you some three-dimensional.
Right, allows you to build a 3-dimensional map so that you're able to do this.
So you know where you're twisting and turning to.
Exactly.
That's really, So you're standing there using fluoroscopy, which is a sort of a real-time X-ray.
Real-time X-ray, yes.
And making these twists and turns. I've never really understood. Is it by manipulating the catheter at the wrist, or are there ways you can pull on it so it changes the tip and changes direction? How do you steer from down here up in the neck?
So a little of both. Some of it is, you'll have wires that go inside these catheters that have different shapes, and you can control the wire by, twisting it to get the shape that you want. And the catheters themselves have different shapes that you can use to, based on the person's anatomy, you can choose the right shape to be able to make these twists and turns that you're talking about.
So once you get to a bleeding aneurysm, so again, try to imagine that as a tube with a bubble on it.
Yep.
And the bleeding is through the bubble.
Correct.
What do you do to stop the bleeding?
Yep, so if we kind of imagine this as a bubble, you're going to try to put a tiny catheter inside that bubble. And then through that catheter, you can put coils, which are what you would think. They're tiny little metal coils, and you basically try to pack or fill that ballooning with coils so that no more blood can get in it. And the goal is to keep the coils inside the aneurysm and obviously not
so
into the
little blood gets
vessel.
there, clots, and then the body, does the body heal over it?
Yeah.
So so you get a brand new blood vessel.
Yeah, over time that'll kind of wall itself off once you've stopped the blood from going in it.
And that's if you have an aneurysm. How about if you just, if you have a clot in that aneurysm, what do you do?
So if there's a clot within the aneurysm, that's not something you generally would do anything about, but that's maybe a good segue to talk about the strokes that
You're actually running out of time.
I'm sorry.
Go ahead. No, it's not your fault. Talk all day.
If we were talking about the strokes, it's kind of the same idea. You use these catheters and wires to get to where that blood clot is, and you can try to either suck it out or use a stent retrieval device to try to capture that clot and remove it from the body to restore blood flow to the brain.
Wow. Now we have 30 seconds left. So how about someone who has just a non-aneurysm, not an aneurysm, but sort of routine blood clotted stroke? Say they have atrial fibrillation, which everybody hears about on TV now. What do you do there with the catheters?
So the main difference is they're a little bit larger, and you're going to basically try to get to that blood clot, either pass through to it and remove it by either trying again to use a suction device or some type of stent retrieval or combination of the two to capture that blood clot and remove it from the body so that the vessel is open.
And we've run out of time, but I want to ask this question, and that is, my understanding is now that this treatment, especially the endovascular treatment, can go beyond the first few hours. We used to have to treat people within 3 hours, or else we were stuck with whatever.
Sure.
You can be beneficial, up to 24? How many hours can you actually do this procedure?
So right now for stroke surgery, thrombectomies, it's up to 24 hours is what the studies are showing. And I think over time, with the better CAT scans that we have and other interventions, that number is going to increase. So
that's fabulous.
As soon as you notice a problem, you should get to the hospital.
Stroke is a treatable disease.
Yes.
And we've got somebody here who is really right at the state of the art with that. This is great. So glad to hear. Nice to meet you.
Yes, thank you.
I'm glad to have you here in the community. That's all we have time for today. I want to thank our guest, Dr. Jonathan Lebovitz, so much for joining us on Health Talk. And I want to thank you for watching. If you have comments or questions, please share them with us by emailing us at healthtalk@newvancehealth.org. We'd love to hear from you.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
(145/92).
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself. I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. I'm coming back. Ask your doctor, check your blood pressure.